There are two types of knot. One is called extracorporeal, other is called intracorporeal. What is extracorporeal? Extracorporeal means you will tie the knot outside and then you will push inside with the knot pusher. There is no role of extracorporeal knot in the open surgery, because open surgery is already extracorporeal surgery, where you have opened the abdomen and your interior milieu is lost and then your hand is inside the abdomen, or you sometimes bring the organ itself outside the abdomen, like bowel loop you are bringing outside the abdomen. Sometime in myomectomy you are bringing myoma outside the abdomen, and you don't need extracorporeal. But in laparoscopy, one of the most important way of doing suturing knotting is extracorporeal knot. Most common extracorporeal knot and must to learn knots are Roeder's knot, Meltzer's knot, square knot, Tay-side knot, Mishra's knot and western knot. Every laparoscopic surgeons minimum these type of extracorporeal knot we must learn. Then you have to learn intracorporeal. Most common intracorporeal knots are surgeon's knot, tumble square knot, Dundee jamming knot, Aberdeen termination and baseball suturing. These are the most common intracorporeal knot. Intracorporeal means you will drop the needle and suture inside the abdomen, just like how you do in open surgery, and with the needle holder you will tie the knot just like open surgery. Those are called intracorporeal. And these all type of intracorporeal we have to learn. If you are doing open surgery, only one knot you learn, surgeon's knot, and throughout the life you can perform the surgery. It doesn't matter what is your specialization. Even if you are a cardiothoracic surgeon, even if you are a urologist, even if you are a pediatric surgeon, only one knot, surgeon's knot, will make you perfect, because you have a help of your assistant. Like if you have a tension in between the muscle after removal of myoma, your assistant is approximating it and you are tying the knot, and once you tie the knot, he put his finger so that knot should not become loose, or he is holding by artery forceps, and then you tie second or third. In laparoscopy, if you will tie intracorporeal first time, there is no assistant finger to hold it. And if you are going for second, then first is loose. So what you will do at that time, you will use tumble square. Tumble square knot has a great capacity of pulling the tissue even under tension. So that's why these type of knots are important to remember. In open surgery, you don't need to learn those many knots, because you don't have a limitation of the help. Your assistant, your second assistant, even you can ask third assistant to help. Many hands are inside the abdomen, and the human hand is the best instrument of the world, made by God. Human hand is the best instrument. You can press, you can have a tactile feedback, you can feel, you can hold, but these all not without learning laparoscopy is not possible. So one by one we are going to learn these all knot. First I will discuss the suture classification. Whenever you have to do suture classification, you have two options. One is absorbable, other is non-absorbable. Most common absorbable suture which is used in laparoscopy is synthetic material. And in the synthetic, most commonly used is Vicryl, then monocryl, then PDS. And in Vicryl also, rapid Vicryl is more preferred because it is white in color. And white has advantage, it reflects light even in the bloody field. Because due to blood there will be red everywhere. And if this red will not absorb the light, it will become dark. But in that red environment, if you have a white color, it reflects the light very easily. So rapid Vicryl is more preferred. Natural is less used, but some people they use natural, that is the collagen and plain catgut. Catgut is almost stopped in most of the developed country because of the hepatitis and other problems, and it is an animal product which is not, it sometimes reacts with the human body. So Vicryl is the best. Now, but sometimes catgut is available, like endo loop. Endo loop is made up of catgut, which is sold by ethicon in the market. Now, non-absorbable you will use like fundoplication, sacrocolpopexy, pectopexy, hernia surgery, you have to use non-absorbable. Non-absorbable also synthetic is more preferred in laparoscopy compared to natural product, and most common synthetic use is nylon, proline, novafil and polyester fiber. These are the most common non-absorbable. And natural product most common use is surgical silk, surgical cotton and surgical steel. Silk is a cheaper this alternative of the absorbable, because these polyester fiber and nylon, that is ethylene, these are little expensive. So silk is a cheaper alternative of non-absorbable. So this is how you will select the suture. These are the pictures of almost all the absorbable and non-absorbable which is available in the world. Most of these products Ethicon is making. Johnson & Johnson you can buy. Now, for a small tubular structure you can use simple chromic catgut also. However, vicryl, and this is called rapid vicryl. Rapid vicryl is more preferred. And for interrupted like hernia, fundoplication, either polyester, nylon or silk can be a cheaper alternative. Silk can be used. Whenever you apply any knot, you must be careful that when you tie the knot should have a correct configuration, it should have a correct shape and it should have a correct snugging. Snugging means locking. Correct configuration, correct shape and correct locking. What is configuration? Every knot has its own configuration. Like, what is the configuration of surgeon's knot? Configuration of surgeon's knot? Bataiye. Surgeon's knot configuration is 2-1-1. First time double wrap followed by two opposite alternating wrap. That is 2-1-1. And that configuration must be correct. If someone is not giving 2-1-1, that means it is not surgeon's knot. If you are tying 1-1-1, that is not surgeon's knot. Exactly same way, shaping, that is drawing. Correct drawing is important. Correct shape is important. Do you know why? In laparoscopy, we don't have a tactile feedback. So, in open surgery, you can touch the knot and you can feel that it is good or not. In laparoscopy, what we have is only visual interpretation. So, it should look good. Just like this tie. Suppose this tie is like that, then you can easily see that he has not made it correctly. Shape is not good, but if it is shape is like this, then anybody can say that, theek hi banda hoga, it is correct. His tie is good, so the configuration looks good because shape looks good. So knot should look beautiful. If knot doesn't look good in laparoscopy, because advantage of laparoscopy, we have 20 times magnification. So knot also looks big. And if it is not tightened properly, it looks ugly. So you just see that knot should look a correct shape. And if the shape is correct, that means knot is correct. And the third is security, that is called snugging, that is locked. And if it is correctly locked, that means it is a correct knot. If it is not correctly locked, that means it is a wrong knot. It is very important to remember in laparoscopy that knots are either exactly right or hopelessly wrong. It is never nearly right. Either exactly right or hopelessly wrong. It is never nearly right. So, if you have a slightest doubt over your knot, you should cut it or leave it and tie another. Don't take a risk, because we don't have tactile feedback. In open surgery, sometimes you tie the knot and you feel that it is not good, but you can touch it and you see, रहने दो ठीक है, काम चल जाए. Means it is good anyway, let it be there, it will work. But in laparoscopy, there is no chance, because during surgery, vein generally they don't bleed due to pressure, pneumoperitoneum. But once you will remove the gas, and if your knot is loose, it will start bleeding once you are sleeping at night. And that is a big challenge in the laparoscopy. So that's why it should be exactly right. Now the first knot which was started in laparoscopy is called Roeder's knot. Roeder has used it first, and this is the most commonly used extracorporeal knot still today. And configuration of Roeder's knot is 1:3:1. That is a single hitch, one hitch. Then you have a three wind, and then you have a last lock, one lock. So one hitch, three wind, and one lock will be taken. How to do that? You will ask the nurse for the finger, and then keep the finger here, and then you will put shorter above the longer, and this is the single hitch is taken. This is single hitch is taken. And after that, three wind will be taken. This is the first wind, this is the second wind, and then third wind. Three wind is taken. And then one lock will be taken on the right side of the limb. And this knot is done. This is one lock is taken on the right side of the limb, and this is done. And after that you will slide it by the knot pusher. And once you slide by the knot pusher, it will do the job. And it can, with the confidence, up to 6 to 8 millimeter of the tubular structure, it can tie. Tubular structure, a structure must be tubular. It should not be flat structure. Tubular structure means what? What are the structure which is tubular? Fallopian tube is tubular, uterine artery is tubular, cystic duct is tubular, appendix is tubular, renal artery is tubular, splenic artery is tubular. So you will take any tubular structure up to 6 millimeter and it will do the job. This is called Roeder's knot. So I will demonstrate you how to tie the knot, first in your hand, and then we will give you. So how you will do that? Here you have the suture. This is the suture, and you will ask your nurse. After that you will take the finger, and this is shorter and this is longer. Now you will put the shorter over the longer like that. This is shorter over the longer, and then always go from below up. Always go from below up. So first I am going in between from below up, and this is the single hitch. After that again I will go from below up, but this time I will not go from middle, I will cover both. This is called wind. Wind means encircling both the limb. So this is taken, and this is first wind. Now this is second wind. Now this is third wind. Three wind is taken, and it's very simple, just encircling both the limb is wind. And then you go in between and just lock it. This is the last lock is done. And now I am sliding it and it is tightened. This is called Roeder's knot. But it has 4 mistakes. 4 mistakes what we do in Roeder's knot. That mistake you should never do. Mistake number 1. When you take this hitch, always keep it pinched by your left thumb and index finger like this, so that this long limb always should remain straight. Suppose I have taken this hitch and accidentally this tail limb I will pull, it get kinked, and now it will never slide. So what I did? I pulled the tail. Remember in laparoscopy, any time you should never pull the tail. If you will pull the tail, you will go to jail. Any time, either you do extracorporeal or intracorporeal. In any knot, you should never pull the tail. If you pull the tail, always remember you will go to jail. So how I did the mistake here? After taking the hitch, I pulled the tail. And see, as soon as I pull the tail, now this will never slide. So how I will prevent it? After taking the hitch, I will pinch it by index finger and thumb. Second mistake. Second mistake is overriding the wind. I have taken this first wind, and the second wind is over the first, and third wind is over the second. This is hopelessly wrong knot. It will not work. So how it should be done correctly? Correctly it should be done that once you have taken a hitch, pinch it by index finger and thumb. And then you take second, again pinch, and again third, again pinch. And then you lock. So see here now, it is stacked 1, 2, 3, stacked. Stacked means one after another. Just like how you are stacking your playing card, or how you are stacking your coins, one after another. First after second, third after second, first, second after first. It should not be that third should be overriding the second, and the second should not override the first. So this is second mistake. What is second mistake? Overriding. What was first mistake? Pulling the tail. Now third mistake. Third mistake, what surgeons they do in the extracorporeal knot is elongation. This is hitch, this is first wind, this is second wind, this is third wind, and then it is locked. And see, it is elongated. This is hopelessly wrong knot. If I will tie, it will never, and then cut, bleeding started. Appendix leak, cystic duct leak, bile leak, renal artery, all everywhere. So this is wrong. So how to do that? You should do proper elongation should not be there. So how to do that? You hold it shorter above the longer, and then this is the first hitch, pinch it, first wind, stack it. See the left hand what it is doing. Second again stack it, third again stack it, and after that do this way, like this. Do you know how we stack our tie? Once all the wind is taken, then you are spreading the loop like that. Am I right? You are spreading or not? You are spreading it to make it conical. What you are spreading? Loop. The same way you spread it. And once you spread it, see it is properly stacked. It will not be elongated. Like this is elongated. How I will correct it? Tell me. By spreading. See? I spread it, it gets stacked. It is elongated. And see, I will spread. Did you see that? So this is which mistake? Third mistake. What was first mistake? Pulling the tail. Second mistake, overriding the wind. Third mistake, elongation of wind. Now last mistake. Fourth mistake is a blunder. When you take this hitch, and then you take the first wind, and then you take second wind, and then you take the third wind, and then when you take the last lock, it should be pulled down. It should be pulled down. But by mistake sometime we pull it up. And once it is pulled it up, it is impossible to slide. Only simple mistake I did. I pulled it up. Anybody of you, please come. You are coming every time, so I will call you only. See, I am giving this loop to him. And he has to slide it. Configuration is correct, shape is also good. But if he can slide, I will give him $100. उसको slide करके दिखाइए. Try? नहीं होगा. Only simple mistake I did. This mistake maximum surgeons they do. I will show you. Come. I will show you because you came here, give your finger. I will show you what this mistake you should never do. See this mistake carefully. This is the hitch correctly taken. This is the first wind taken correctly, second wind taken correctly, third wind taken correctly. I am spreading. See this spray also I am doing like that, right? Everything is correct, extract also properly. But when you are taking last lock, look at this. I have to pull it down. Am I right? What I did, I pulled it up. ऐसे ऊपर कर देंगे ना तो now it will never slide. Try to slide. Not sliding. So, what is this mistake? Wrong snugging. Wrong snugging means wrong locking. That's why I told you what are the 3 stages of knotting. First stage is configuration. Second stage is shape. And third stage is locking. So here what was wrong? Locking was wrong. Locking was wrong. So these 4 mistakes you should never do. Now second knot. This is Roeder's knot. Now second knot is Meltzer's knot. What is Meltzer's knot? Meltzer and Roeder's has no difference. Meltzer knot, Meltzer has, it is also called in some of the book, they are giving this knot a name that is called modified Roeder's knot. Modified Roeder's knot is called Meltzer's knot. What Meltzer has done to make it more powerful for monofilament, because Roeder has invented this knot where maximum number were using the catgut. In 70s, at that time what was there? Catgut. In 80s, monofilaments were used like PDS or monocryl. Monocryl was not in 70s, it was launched in 80s. So then Roeder was little loose. So Meltzer has, what he did, he added one extra hitch and one extra lock. So Meltzer's knot is 2:3:2. This is Meltzer's knot. That is 2:3:2:3:2. This is called Meltzer's knot. And Meltzer's knot can take up to 12 millimeter of structure. Very confidently you can take. Like renal artery, splenic artery, in mass ligation in cholecystectomy, cystic artery, cystic duct together, or partial cholecystectomy. In all those cases, Meckel's diverticulum, cervix after supracervical hysterectomy, you can use Meltzer's knot. And it has a configuration 2:3:2. So we will see how to tie this knot. So 2 hitches will be taken first. This is first hitch. After that you will take second hitch. This is first hitch, then second hitch, and then you will take 3 wind. Wind is same. This is first, this is second, and this is third. And then 2 lock will be taken on the right side of the limb. 2 lock will be taken on the right side of the limb, and that is called Meltzer's knot. So it is very simple. So again I will show you how to tie this knot. This is Meltzer's knot. So same way suture will be taken, and mostly it is used for continuous structure. Continuous structure, remember there are 2 types of structure in laparoscopy. One is free structure. What is free structure? Appendix. In that you can use pre-tied loop. Pre-tied loop. Pre-tied loop, just like pre-tied it used to hang the criminals. They have a pre-tied loop. They are putting in the neck of the criminal and they are hanging. That is also extracorporeal knot. And continuous structure like cystic duct, renal artery. Renal artery you will not cut and then you put the loop. You have to encircle. And whenever you have a continuous structure, minimum length of the suture should be 90 centimeter. And for pre-tied loop, it should be 75 centimeter. So Meltzer is mostly used for continuous structure. Then here what you will do, again same way, shorter above the longer. In the Roeders, once you put the shorter above the longer, then this length should be 6 centimeter. ये वाला tail length. And in the Meltzers, it should be 8 centimeter. Why? Because you need extra wind and extra lock. And then you will take, this is single hitch, then you will take double hitch, then you take the first wind, then you take the second wind, and see left hand, what left hand is doing. Then this is third wind, and what you do? Spread. Why do you spread? To stack. And then you will take, this is the first lock, it is done, and after that you will take second lock, it is done. And this is which knot? Meltzers, and it is sliding. And do you know, it can take the structure up to 12 millimeter. 12 millimeter structure, like renal artery, splenic artery, uterine artery, supracervical. In mass ligation, partial cholecystectomy, all you can use Meltzer's knot. So this is the Meltzer's knot. Now another last extracorporeal knot which is important is called Mishra's knot. Question is, why Mishra's knot? As I told you earlier that extracorporeal knots we do 4 mistakes. First mistake, pulling the tail. Second mistake, overriding the wind. Third mistake, elongation of the wind. And last mistake, that wrong snugging. Now in Misra knot these mistakes doesn't happen. Because configuration of Misra knot is 1, 1, 1, 1, 1. So what is the advantage? That it can take the structure up to 18 millimeter, and configuration is 1:1, 1:1, 1:1. So you take a single hitch, after that take one wind, and then you lock it. Once you lock it, now it cannot elongate. Now you take second. Because first is already locked, so second cannot override the first. And then again lock it. And then you take the third and again lock it. And now the beauty of this knot, no possibility of snugging, no possibility of overriding, no possibility of elongation, and no possibility of wrong pulling the tail, and then it slides. And this is possible to do up to 18 millimeter of the structure. So I will show you how to do this knot. Very simple. Here also you will hold, ask the assistant for the finger, put shorter above the longer, and similarly here you will take first hitch, then you take first wind, and then you lock it. It is locked. Then you take second wind, and again you lock. It is locked. And then you take third wind, and again you lock. So it is more stacked if you will see carefully, and there is no chances of elongation and no chances of wrong snugging. So this is Misra's knot. Now you will ask, suture material, is it more used here? No. In the Meltzer, in the beginning 2 hitches, and at the end 2 lock was there. And here only difference is it is distributed in between the wind. Here also 4, but it is in between the wind. First is hitch, second is wind, third is again lock, fourth is again wind, and last is again lock. So here also wind is 3. Here also lock is 4. In Meltzers, 2 in the beginning, 2 at the end. But here it is in between. And that's why no chances of overriding, no chances of elongation. Now another problem. Another problem is why these knots are getting sometime overridden, sometime locked, sometime bad snugging. Do you know why? Because you are looking at the knot. You should never look at the knot. If you are, during tying, you are looking at the knot, that means you don't know how to tie the knot. Just like you are driving a car and someone come in front of your car and you are looking at the brake, where is the brake, where is the brake, you will kill the person. Your brake should know, your leg should know, your foot should know where the brake is. So during practice, always practice with the closed eye. How I will show you. It is very simple to tie this knot. Only these 3 fingers you have to use. See, I close my eye. My eyes are closed. And see, I will tie soon without any help. Hold it this way. Can you see that? Put it here. Index finger up, thumb up. This is one hitch. This first I am tying daughter. Again you go. Index finger up, thumb up. This is one wind. Again you go. Index finger up, thumb up. This is second wind. Again you go. Index finger up, thumb up. This is third wind. After that you go in between and press by this thumb, left thumb. And it is done. Why should I see that? I should not see that. And tight. Done. If you are looking at the knot, you don't know how to tie the knot. Have you seen any soldier when they go to when we go to fight for the country, are they looking for their gun? No, they don't look at the gun. Where they look? At the enemy. They don't look at the gun, where is a trigger, where should I put my finger? No. That their finger knows. They only see the enemy and then they fire. If you are looking at your gun, you are not trained. So, again I will show you Meltzer. How to tie? Always close the eye, like this. And all these 3, see, this is first hitch. Index finger up, thumb up. Again second hitch. Index finger up, thumb up. Again you go, index finger up and thumb up. Again you go, index finger up, thumb up. Again you go, index finger up, thumb up. Again you go and press by left thumb here and pull it. You don't have to look at this and it is done. Again I will show you Mishra's knot. Same way, you don't have to touch and you don't have to look. Always practice. Take this at home and at night switch off the light of the hostel. And in the dark use your table lamp or any tubular structure and just close your eye like this. And again you hold, see, index finger up, one hitch. Again this is one wind. Again this is one lock. Look at this, I am not seeing at all. This is second wind. And again it is done. And press it by the left thumb. This is second lock. And this is the last wind. And again this is last lock. Why? I should not see that. If you are seeing, you are not trained to tie the knot. Your finger is knowing that and your finger has done it. See, done last. And then slide it. It's done. You don't have to see that. And if you are seeing, that means you are not knowing how to tie the knot. So this is called Mishra's knot. And this is the, what is the configuration? Configuration is 1:1:1:1:1:1. That single hitch, then first wind, then first lock, then the second wind, this is second lock, third wind, third lock. If you tie extracorporeal knot with the confidence, many of the surgery will become so easy for you, like pedunculated myoma, then the retrocecal appendix, bad cystic duct cystic artery in mass ligation, partial cholecystectomy or supracervical hysterectomy. These all surgery become easy. So some of the clinical cases I will show you. So you will see that what is the real need of these knots. So I am showing you some of the clinical cases that where these knots are used. Like first for gynae I will show you. Like suppose you are doing myomectomy. And this is the myomectomy surgery and you have a like large pedunculated myoma here. And this is a large myoma pedunculated. And you have to do the extracorporeal knot. And we will see here. This is a 24 centimeter big myoma. Look at this. It is reaching up to the falciform ligament. Can you see that? This is falciform ligament here. And it is reaching up to the falciform ligament. And that is a big myoma like this. A small uterus, big myoma. and you can do in 5 minutes. It will not take more than 5 minutes to perform this surgery. Just 5-minute job. No need of vasopressin. No need of any other thing. You will go and you will go with the one grasper, and first you check that there is no adhesion. It is not fixed anywhere, it is mobile. Check those bowel loops are not adhered. Because if there is any adhesion, the first thing what you have to do is adhesiolysis. So there is no adhesion, it is fine. Now you will go with a vicryl, number 1 vicryl, and just you encircle it. Go from inside and bring it from other side. When you are encircling it from below, this is for continuous structure. And free structure, already all of you know, appendectomy is the example. All of you must have done appendectomy also. And then you encircle and bring it out. Same suture you bring it out. And you can see pedicle is around 18 millimeter, 2 centimeter in diameter. But that much thick pedicle also this knot can easily control. Now you are feeding it. Why you are feeding it? Because when you pull it, there should not be any shearing effect. So it is feeded. Your sutures are feeded. After feeding it nicely 4 times, so that at least 20 centimeters should go inside, then you catch the another suture and then guard it by the grasper and pull it out. This is how we tie even renal artery, splenic artery, even uterine artery, we tie same way. And then take it out, and you see this is the knot. This is the outside, this is the one hitch. This is the one wind, and this is the one lock, then second wind, second lock, third wind, third lock. So index finger up, thumb up. Only 3 finger has to work, and it's done. After that, you will slide it with the knot pusher. And wherever you keep the knot pusher tip, knot will come there, like the base of the myoma, in the touching the uterus here, touching the uterus. So that absolutely tight. You can see any part of the myoma was not left. It is dumbbell is formed. And after that, you just tight it as much as you can. And then what you do, just you keep this suture 6 to 8 centimeter long and then cut. Extra suture you will cut, and this extra suture is cut. After that, what you can do, you can wrap this suture around this grasper. Look at this, it is wrapped, and now it is acting as a traction. And you know, the beauty of this knot is, more you will pull, more it will become tighter. This is the beauty of extracorporeal knot. That's why it's called slip knot. More you will pull, more it become tighter. That's why when they hang the criminal, they hang by extracorporeal knot. They just put it on their shoulder, criminal shoulder, just like a garland. They say, don't worry, nothing will happen. And they put it there. And then they open the box down. And once they pull it, more body weight they want to escape, more it will, easily they will die. And it break their vertebral column also. But only vertebral column breaking is not death cause. Death cause is asphyxia. Because vertebral column breaks, but that after that also they are live. But more they are escaping, more it breaks. That is the beauty of extracorporeal knot. More you pull, more it become tighter. And that's why you can wrap, and here the suture itself is acting as a retractor. You know, if you will tie intracorporeal, you cannot pull like that. It will be out. It will be loose. But extracorporeal, more you pull, more it become tighter. And then you can easily cut. Harmonic is cutting it, and you can see during cutting, here bleeding has started. But look carefully, this bleeding is not from uterus side. Carefully look it. And if you see here, this bleeding is from myoma side, collected blood. Uterus side is dry. So don't worry about that bleeding. That bleeding is good because it will shrink the myoma. And this is from myoma side. Uterus side is dry. See, this bleeding is from this side. Here. Did you see that? And now it is cut. And after that you can morcellate. Now only drawback that this raw area can adhere somewhere. So after cutting it, you can cover it by interseed. That is reoxygenated cellulose. You can cover it by interseed. Interseed is a mechanical adhesive barrier which is better after myomectomy so that bowel omentum should not get adhered. So if with the extracorporeal knot, it can easily apply and you can perform this type of pedunculated myoma very easily you can perform. And now this remaining suture you will trim out. You can hold it with the grasper, and then harmonic can cut suture as well, and it is cut. After that remove it, and then you can use some suction, and then you can bring the interseed. So just I am taking a little forward. This is interseed which is covering the area, and then spreading the interseed nicely, and so that adhesion will not happen. This get absorbed, this is absorbable. Within 1 week it get absorbed. By the time serosa will cover it, and then you will morcellate. So this is morcellation going on. So this type of surgery is not possible to do without extracorporeal knot. However, there is another way. You can use it by simple, this vasopressin injection we can do, and we can do by simple technique. It is not necessary that only this knot will work, but I have just shown you one example that how these knots are useful. So this is the knotting and suturing. Now master the needle dance, precision is every glance, master the art of thread to thread, and laparoscopic suturing lead ahead. This was called by Professor Kusieri that suturing and knotting is the best method of tissue approximation. So today we have seen little bit about extracorporeal knot. Now I will give you one small break again, 5 minutes. After that all of you have to come in the lab, and then I am showing you how to tie this extracorporeal knot. After that all of you will practice how to tie this extracorporeal knot. And afternoon, after practicing again 1 hour, then we will have another session. Is there any question regarding this? Any question? Any question regarding the extracorporeal knot? So just have a break and then come to the lab. Thank you very much.